Hello.
Good afternoon, everybody. I thank the organizers and my dear friends Sudhakar and Subbu for giving us the opportunity to chair this session. And the speaker is none other than Meena Kumari, Mohan from Coimbatore. Actually, I will introduce Pandrakku Munada. I thought kindly excuse the other language barriers. In Tamil, I wanted to give a small kavidai. சிறுவாணி தண்ணி குடித்து சிந்தையை பகர வந்திருக்கக்கூடிய சிரித்த முகத்தாள் சிங்கப்பெண் மீனா குமாரி மோகனை வரவேற்கிறேன். Over to Meena Kumari.
Mikka Nandri Ayya. Thank you very much. Very good afternoon to all of you. So I have a talk on the introduction of long-acting growth hormone called Somatrogon in children with pure GHD and inspiring about new treatment options. So I just have to disclaim that all these slides were made by Pfizer and I have not made any alterations to the content provided. So what we have found that the once daily growth hormones adherence is not that great, and in order to find out the adherence pattern, there was a study done in New Zealand where the caregivers of children and adolescents receiving publicly funded growth hormone self-reported the number of GH vials required each month via phone and returned used growth hormone vials in an unbiased, unanonymized national survey during a single 4-month interval in 2007. And the results revealed that their linear growth was significantly reduced, as you can see, with missing more than 1 dose per week. And 66% of children who missed more than 1 dose of growth hormone per week had significantly reduced height velocity SDS. So this states that what we have to do is we have to find out ways of improving patient adherence. So for that, they have come up with this study where only 52% reported children were actually stopping growth hormone much earlier than necessary. And that was due to various factors, especially in adolescents, looking at factors like denial, peer pressure, reluctance to seek advice from medical professionals, treatment fatigue, forgetting to take the injection, painful injection sites, etc. And most of the women stopped the treatment much early on. So what they found, even the caregiver had fatigue with the patient themselves and even the clinicians, in that they actually lost interest when the patients did not get better with the adherence pattern at all. So what was found is that they found that in other departments like hemophilia and type 2 diabetes, the adherence was better when the prophylaxis was changed to once a week, instead of 2 to 3 times a week. And also in type 2 diabetes, from once a day GLP-1 agonist liraglutide to once a week exenatide. And this also showed that there was an improvement in treatment satisfaction, improved quality of life, and also good homeostasis, low bleeding rates with good safety margins for the hemophilia group. So this wanted or made us to actually improve the outcomes in terms of increasing adherence by decreasing injection frequency, potentializing the maximum efficacy, and potentializing the improving adherence, and also increasing the flexibility so that they don't have to stick to same time, same place every day in order to get the medications. So what they did was they actually brought the HCG molecule into the human growth hormone molecule and added the CTP molecule in 3 places of the human growth hormone, which extended the half-life of human growth hormone by at least 10 times. So what was 2 to 3 hours for the recombinant human growth hormone was made into 28.2 hours, that is nearly 10 times, so that will increase the efficacy of the long-acting growth hormone. And they also found that the action and efficacy was not compromised. So looking at the efficacy and safety data, there were actually totally 6 studies in total. 2 of them are ongoing and 4 of them have been completed. 2 of them are phase 2 trials and 4 of them are phase 3 trials. And the phase 2 study was a multi-center safety and dose finding study in children with growth hormone deficiency, including a main study that evaluated 3 weekly doses of Somatrogon, that is the weekly once preparation. So they were randomized into 4 cohorts. One of them received a small dose of 0.25 milligram per kg per week. The next cohort received 0.48 milligram per kg per week. And the final cohort of the once weekly vial and syringe received 0.6 milligram per kg per week of the once weekly molecule. And there was one cohort that was assigned to receive once daily somatropin dose at 0.34034 milligram per kg per day. So at the end of the main study, which went on for a year, they then randomized the group that received the once daily dose to all the three variants received, namely 0.25 milligram, 0.48 milligram and 0.68 milligram per kg per week. So that went on as an open label extended study, and then they went on for another year on the vial and syringe, and then it was followed by the same medicine via pen device for another year as an open label extended study. So the inclusion criteria was that it was only pure growth hormone defective or insufficient prepubertal children with no other concomitant pathology involved, and the age was between 3 and 10 years for girls and 3 and 11 years for boys. And the growth hormone levels were noted to be less than 10 on 2 different stimulation tests, and the bone age was less than the chronological age or equal to 9 years in girls and 10 years in boys. And the karyotype was assigned to be normal for girls, and the impaired height, that is more than 2 standard deviation below the mean, impaired annualized velocity SDS less than 0.7, meaning less than the 27th percentile for the chronological age, and an IGF-1 SDS score of less than or equal to -1 was taken as the inclusion criteria. And they found that there was key efficacy and safety endpoints. So the primary outcome was the annual health velocity at 12 months, and the secondary outcome was the same at 6 months, and also any change from the baseline in height and SDS at 6 and 12 months, and also change in IGF-1 SDS score from the reference population. And also the safety, adverse effects on immunogenicity and pharmacokinetics and pharmacodynamics of all the serum IGF-1 values, IGF-BP3 values and Somatrogon pharmacokinetics were all put into place. So the baseline demographics were pretty much same in that the age group was pretty much the same, and it was mainly white Caucasian boys was the main population. The peak growth hormone values, the height SDS mean and the IGF-1 SDS mean were all comparable between the two groups. And they noticed that when they were on a smaller dose of Somatrogon, that is once weekly preparation of 0.25 milligram per kilogram per week, the height velocity was 10.4 against the 0.48 milligram per kilogram per week, which was 11. And when the dose was optimized to 0.66 milligram per kg per week, it was in comparison to the 0.24 milligram per kg per week, which is the dose that has been made equivalent to a weekly dose, though it was given on a daily basis. So they also found that the once weekly Somatrogon demonstrated a 10 times longer half-life compared to the daily growth hormone injections. So you can see that the Somatrogon half-life was 28.2 hours compared to the 2 hours for the once daily preparation. So the treatment emergent adverse effects were also seen, and one could see that only on the highest dose of Somatrogon you can see injections like erythema, swelling and hematoma that was present, but otherwise the side effects were similar in comparison between the daily injections and the weekly injections. So also the IGF-1 SDS trends, they noticed that with the highest dose, the IGF-1 levels were slightly on the higher side for a very short time, and then they actually were within the normal range. They also, when they found out the yearly levels of IGF-1, when they continued for a prolonged period of time, all the four were in comparison with each other. So now looking at what difference it made in terms of height velocity at 12 months, you can see the bottom end with the blue graph that definitely there was significant improvement in the height gain in terms of mean height SDS in the first year compared to the following subsequent years. However, one could see that there was definite improvement. Looking at the mean cumulative change in height SDS, the number keeps on improving, because if you look carefully, the number that was entered into the trial kept on increasing, and that is why there has been an increase. So at the end of 5-year data, you can certainly see that there is an improvement in terms of mean cumulative change in height SDS and also good improvement in the mean height SDS. They also looked at the treatment emergent adverse effects, meaning what are the adverse events that came out because of the treatment that was given, and that was looking at the first 4 years of the open label extension period. And again, this was very much comparable, and what they could find is only the injection site reaction, which was moderately severe, which actually made at least one of them to stop the injection because of adherence reasons, because of the complications. But otherwise, there wasn't any significant side effect that was noted. So in terms of safety summary, they could found that in both in the main study and also in the open label extension study, Somatrogon given once weekly was associated with the favorable outcome both in terms of safety and tolerability, which was consistent with the known properties of recombinant growth hormone that was given on a daily basis. Also in the main study, it was found that the adverse drug reactions was almost comparable. And if you note carefully, it was noticed that the adverse drug antibodies was more to the human growth hormone part of it rather than the CTP molecule, and that was how the single daily dose of growth hormone was made, the half-life of it was increased. So they found that though the antibody levels were higher, it did not have any problem on the safety or the efficacy of the height velocity change in what the molecule brought out. So the phase study concluded that based on the 12-month height velocity, a dose of Somatrogon of 0.66 milligram per kg per week was chosen as the dose that was comparable to a 34 microgram per kg per dose somatropin, which was a daily dose for the phase 3 study. So phase 3 study was a multicentric study that happened over 83 clinical sites, of which India was one of them, and it included a total of 21 countries. So what was done, they actually screened the children that went into the study over a 12-week period, and each of them were randomized on a 1-to-1 ratio for a dose of 0.66 milligram per kg per week for the once weekly preparation and 0.034 milligram per kg per day preparation for the once daily one. And then this was an open label treatment that was randomized for a 1-year period, and at the end of it the height velocity assessment was made, and then they were all converted to the once weekly preparation that they were ongoing as an open label extended study. So these were the key inclusion criteria, which again mentioned that they had to be straightforward prepubertal children with growth hormone deficiency. Again, the age criteria was the same. The peak plasma growth hormone level was less than 10 on 2 different stimulation tests. The bone age and chronological age was less than 10 for girls and less than 11 for boys. Again with a normal karyotype for girls, and the same specifications for the height velocity SDS and IGF-1 SDS levels. The primary endpoint was again looking at the height velocity at month 12, and the secondary endpoints was looking at the same at 6-month period, and also looking at the height SDS at 6 and 12 months. Also was noticed was the change in bone maturation at 12 months, looking at the change in bone age as well measured by the Grulich-Pyle method. And IGF-1 serum SDS levels were also taken into account. So what they found that again the baseline demographic groups were similar between the two, and there wasn't much difference. It was mainly males, and it was the white Caucasian was mainly involved. So of screening the 536 children, only 224 participated. They were randomized and 222 completed the study. So the primary endpoint, which was again visualized and the annualized height velocity as centimeters per year, they found that the estimated height from somatropin was 9.78, and they thought that anything that was about minus 1.8 to that was in comparison with that, but they found that the weekly presentation was even much better compared to the once daily preparation, being the confidence interval being more in favor of somatrogon rather than somatropin. So once weekly somatrogon was non-inferior in any way to daily somatropin with respect to annualized height velocity after 12 months of treatment in children with growth hormone deficiency. They also found that the age, sex and pre-growth hormone groups showed similar height velocity response to both the groups. They found that those who had the least amount of growth hormone, that is less than 3 nanograms per ml, had a even much better favorable outcome, and also the girls favored better than the boys. So this is a graph that is looking at the achievement that was very much similar in the height SDS that was achieved compared to the weekly preparation to the daily preparation, and they found that the LMS difference was definitely better. Both of them were doing well, and the weekly preparation was slightly better than the daily preparation. So patients achieved similar bone maturation to daily growth hormone along with weekly growth hormone levels. So this was a slide that was shown, made to show that the IGF value normalized at 1 month of Somatrogon treatment and continued to maintain the same both for the weekly and the daily preparations. So the safety profiles were also very similar, and as I mentioned earlier, the main thing was the injection site reaction that was of moderate severity that actually made one individual to stop the treatment in between. But the efficacy and the safety data continued to remain the same and was equal for both the groups. Overall, treatment-related adverse events report were the same, and all the side effects like headache, pyrexia, cough, vomiting were not related, and they were similar to both the groups. The one thing that to be noted was the injection site erythema and the pain and the hematoma again, which was clearly explained in the previous slide as well. So what they found that though the antibodies was positive and the antibody negative, but that did not have any effect in the height velocity difference between the antibody positive groups and the antibody negative groups. So the phase 3 study summary showed that none of the antibodies had a definite role. The safety was better, the efficacy was better, the tolerance was better, and the adherence was also better with the once weekly preparation. So this is the phase 3 non-inferiority study comparing the weekly and the daily preparations. So the screening happened over 12 weeks, and again there was a one-to-one randomization between the two groups, and this was an open labeled treatment that was given for 52 weeks, and then they were all converted to the weekly preparations, and the trial is still ongoing as open label extension. So here again the groups are very much comparable, and it was again the male and the white that was more of the children were in that group, and most of them were in the severe GHD. And what was found is again the height velocity was comparable between the two groups. Though initially there was slight difference, but the overall height SDS was comparable between the two groups, which proved that the weekly preparation was non-inferior to the daily preparation. This is the phase 3 trial where there was a crossover. So initially the group A, which was on daily dose, was then switched on to the weekly dose, and the vice versa. And this carried on for a year, and afterwards, 12 weeks, and then after a 12-week period, then the crossover was done, and at the end of the 24 weeks, the study was over. And this also showed the similar inclusion criteria, and the endpoints were pretty much the same. So the patient disposition was also the same. So there were at least one who stopped from the study, stopped the therapy, but the others all continued. And again, the efficacy and the safety data continued to be in comparison with the single daily medication. The baseline demographic and baseline characteristics all continue to remain the same. So this is actually showing that both the data are comparable, and the p-value was very significant with probability of less than 0.0001%. And again, the confidence intervals, everything shows that it is all more in favorable of the weekly preparation rather than the daily preparation. This was a study to show that actually whoever missed the doses definitely had poor health velocity at the end of 12 weeks, and there was none who actually missed a dose in the first 3 years of the study. So once weekly Somatrogon delivers a treatment experience that was favorable both for the patients and the caregiver. So the adherence was not an issue, and because the process was better, the product was also better, and they showed that the side effects are also very much comparable between the two groups. So summary of the treatment burden study is that injection site pain was the most common side effect, but otherwise everything else was in comparison between the two groups. So what they have showed is GHD is the most common pituitary hormone deficiency in children, and major clinical features are short stature with poor growth velocity. Accurate and timely doses is very essential. Adherence is very necessary, and if it is suboptimal, then obviously the treatment outcomes are also going to be affected. So long-acting preparations of growth hormone have the potential to improve adherence and therefore improve clinical outcomes. So Somatrogon is now a new molecular entity comprising the CTP molecules from the beta chain of HCG that has been fused to the recombinant growth hormone, thereby increasing the half-life of at least 10 times for weekly dosing. And phase 2 and phase 3 studies have very clearly demonstrated that the annual height velocity achieved with once weekly preparation is definitely incomparable with the once daily preparation. And the most commonly reported side effect was the injection site reaction. So they have come up with this molecule from Pfizer called Genrizon, and so this explains the efficacy and safety data. Thank you very much for your understanding. Thank you.
Thank you, Dr. Meena, for completing in time. Is there any questions from the audience? We have 1 more minute. So there are no questions. Thank you. Thank you, Dr. Meena.
Thank you very much. Thank you.
Thanks to the chairperson and the speaker for the session.